Thank you.
Good morning, thank you. Glad you've already come to your conclusion. This is a talk on aortic valve, conventional aortic valve surgery as the gold standard. If you think it's TAVI, the gold standard, you're actually in a different auditorium this morning. TAVI is the gold standard for inoperable patients with severe aortic stenosis. This was a recent quote from the European Society of Cardiology, and I'm not sure there's much to quibble with that. If the patient's inoperable, the only thing to comment on is that is it going to be cost effective for patients who have inoperable disease? But we won't talk about that this morning. However, Everard Gruber made this statement also this year. I don't think that surgery will be obsolete, but if I can look forward in a couple of years, TAVI will go into a lower risk population. But for the most part, surgery will remain, at least for the next 4 or 5 years, the gold standard. So we have 4 or 5 years really to sort out this problem. What do we know about conventional aortic valve surgery? Well, we know that the mean age of aortic valve replacement is rising, and there's an increased predicted operative mortality. However, there's also a decreasing operative mortality and stroke over the past 10 years. And you would expect a mortality risk now of about 2.5% for patients under 80 for all comers, and about 1% for patients under 40 years. And we also know from registry data from both sides of the Atlantic that there's been a marked shift in the use of bioprostheses in the registry data. This is the results of the UK first-time aortic valve replacements over the past 10 years. So from 2001 to 2010, the mean logistic Euroscore has risen over the past 10 years from 6 to about 7, but you note that the operative mortality has decreased from just over 3% to about 1.5%, along with a decrease of CVA risk to about 1%. So what are we comparing standard aortic valve surgery against? We can compare it against medical therapy, balloon aortic valvuloplasty. I won't dwell too much on minimally invasive AVR because that's going to be talked about later, but I guess the main competition is going to be TAVI. And if we're looking at TAVI, what about the subgroups of TAVI? Certainly patients with concomitant CABG, coronary artery disease, porcelain aortas, frail patients, etc. And also, if we're looking at patients, are we assessing them properly in terms of scoring systems? Are we using the appropriate scoring system to measure both mortality and morbidity? Are we looking at frailty correctly? And what are the incidence of paraprosthetic leak, prosthetic dysfunction, the durability of prostheses, and the complications of any procedure that we do? So this slide shows patient survival or people's survival if they have comorbidities according to age group. And as you can see, even in the age of 80 and above, if you have little or no comorbidities, your long-term survival is actually quite good, or your four-year survival is quite good. If you have a lot of comorbidities, whether you have aortic stenosis or not, your long-term survival is poor. And whether any intervention in this age group makes any difference, it has to be questioned. So we look at medical therapy. I don't need to dwell on this long because it's just been discussed, but aortic valve stenosis is a pretty miserable disease. And if you have heart failure, your mean time to death is 1.5 to 2 years. And there is a high incidence of sudden death in this patient group. Balloon aortic valvuloplasty, traditionally used either for palliation or as a bridge to aortic valve surgery, but now increasingly used as a bridge to TAVI, and is to get expected results in improvements in left ventricular function, pulmonary hypertension, and severe mitral regurgitation. However, it results in incomplete relief of obstruction. The benefit can only be measured in terms of months, and although it has a low procedural mortality rate, there is a high complication rate, particularly in terms of stroke and acute aortic regurgitation. The long-term survival is not affected by balloon aortic valvuloplasty. Minimally invasive AVR, I was surprised that I only found 4 randomized trials of minimally invasive versus conventional surgery. And a fairly recent meta-analysis by John Pepper's group basically came to the assumption that there was no major clinical advantage of minimally invasive, although it does produce better cosmesis. So we have current guidelines for surgery, and we have current inclusion criteria for TAVI. And the guidelines, as we've already said, are severe aortic stenosis or asymptomatic aortic stenosis without symptoms with poor left ventricular function. The inclusion criteria for TAVI, severe aortic stenosis again with symptoms, with a life expectancy greater than a year and either inoperable or high risk for surgery. We must take note that a fair proportion of patients don't have the advantage of getting repaired for any procedure. So I work in Scotland, and we are one of the few countries in the UK that, in the world, that does not have TAVI. And one of the reasons we don't have TAVI is that we have a healthcare improvement group consisting of mainly public health physicians, but also, for this case, cardiologists and cardiac surgeons. And we're asked to come up with an evidence-based plan of whether TAVI should be funded in Scotland. And I just wanted to mention some of the key points of the findings of the report that we produced. And in particular, there was only one randomized controlled trial, as we know. Again, I won't go into the details of the partner trial, but there were two cohorts, one of TAVI versus surgery in high-risk patients, and cohort B of TAVI versus medical treatment. It should be noted, however, that the mortality rate for TAVI and for surgery was lower than predicted in both groups. But the other key points they found was that TAVI is associated with a higher incidence of vascular complications and neurological events compared to surgery. There is very limited data on outcomes beyond a year, limited information on the quality of life after TAVI, and at that time there was currently no published evaluation on the cost effectiveness of TAVI. And as we've already seen in a different format, but there were a large number of trial exclusions, so that we have no randomized data on, for example, patients with coronary disease undergoing these procedures. This is registry data, mortality rates and risk by logistic Euroscore. And as you can see, the only randomized trial we have has the lowest mortality group, mortality results in these findings. Although it's a high-risk group of patients that have received TAVI, the mortality rate is really quite high as well. So, aortic valve replacement with concomitant CABG versus TAVI and PCI. As we've heard, there's no randomized study, and there is no consensus of when or if PCI should be done. We know that a large proportion of patients who come to TAVI have coronary artery disease, and various strategies have been reported from basically ignoring the disease and just managing it medically to doing a staged procedure with either drug-eluting or a bare metal stent in the future. We do know, however, that patients who have coronary disease and undergo TAVI have a much higher chance of dying within 30 days. So if we compare that to surgery, and again, this is the UK results over the past 10 years, and as you can see, the mortality rate has also dropped in the UK from over 6% to just over 3.5%. The stroke rate has remained much the same. When we look at now the subgroups of aortic valve replacement with patent grafts, again, no studies to compare one against the other, but there have been many studies reported of large numbers in the literature with relatively low mortality rates for what we would consider to be a technically difficult procedure. For failed aortic bioprosthesis, we recognize this to be a high-risk procedure, and the mortality rate, certainly for 80-year-olds, is about 5%, which would increase in the presence of comorbidities. Valve-in-valve TAVI has been increasingly reported as being feasible. There's a decreased incidence of heart block, presumably because they already have a ring in position which can't be dilated anymore, and at the moment it's limited by small bioprostheses, but that may change in the future. 10% of patients who are over the age of 65 at implant of an aortic, however, will need further surgery, so we have to recognize that even bioprostheses do have their limitations. However, that 10%, a large proportion of those are actually having operations for infection. Porcelain aorta, again, disappointed to find a lack of literature on this. There are various case reports of successful outcomes and techniques of how to do it. There seems to be a high incidence of medical management of these patients. Whether this will change with the introduction of sutureless valves in the future needs to be studied. Concerning radiotherapy, again, very limited literature about this. There does appear to be a dose relationship between the amount of radiotherapy received and the amount of radiation-induced heart injury, but certainly in my practice we wouldn't turn anybody down because they've had previous chest radiotherapy. Frailty, there are a number of definitions of frailty in the literature, and whichever one you use, if you relate it to outcomes of cardiac surgery, it is related to it. So the more frail you are, the more, and certainly in terms of muscle weakness, the greater the risks of perioperative mortality and the amount of complications you can get. There has been a resurgence in the number of publications regarding elderly patients recently, no doubt because of the threat of TAVI. And certainly large series have published quite low mortality rates for elderly population. And even elderly with a high Euroscore, there's one large study of an 8.4% mortality risk in this group. And patients certainly should not be turned down just because they're old. Concerning paravalve leak, TAVI actually has quite good forward flow, and the gradients are relatively low, no doubt because of the size of the valves that they're putting in, but it does seem to be at the expense of paravalve leak. And certainly moderate to severe paravalve leak is reported in up to 15% of TAVI, and the same incidence of severe paravalve leak is 1.5 to 2% for conventional aortic valve surgery, so it's much lower. We also know that paravalve leak is associated with a higher mortality rate if it occurs. Durability. TAVI devices have been durability tested out to 10 years, fatigue tested for 10 years, and there have been no reported failures in the longest report, which is at 5 years. For conventional surgery, we must remember again that structural valve deterioration does occur, and even at the age of 75, 13% of patients can expect to suffer from structural valve deterioration. Stroke rates, we've also heard that there is a high rate associated with TAVI, about 2% in conventional AVR and up to 10% with TAVI. But of more concern was a recent MRI study looking at the brain's post-conventional surgery and TAVI, and found that there was an 84% of embolic events occurring, although most of them were subclinical in TAVI patients. Permanent pacemaker, we must remember it's quite high in conventional aortic surgery as well, with rates of up to 18% reported for conventional aortic valve surgery, but up to 40% with TAVI. And both the source registry and the partner study has shown quite high rates of vascular complications with TAVI, up to 17%. Now, if we're looking at scoring systems, we know that logistic Euroscore overestimates mortality in TAVI cases, and we also know that there is poor calibration of high-risk patients as well. And clearly we need to look at different scoring systems for this. But I guess it's not surprising. Certainly with TAVI, none of the scoring systems will actually look at what we consider to be high risk for TAVI in terms of frailty, peripheral arterial size, porcelain aorta, or even patent grafts. So the application of scoring systems of TAVI has to be questioned, and I think a system for TAVI needs to be developed which is separate. So in conclusion, conventional surgery I still think remains the gold standard for the definitive treatment of aortic stenosis. And we need to do randomized trials of the subgroups of patients undergoing TAVI at the moment. Elderly patients with no comorbidities have a low risk associated with conventional surgery and have excellent proven long-term outcomes. Surgical scoring systems do not predict individual patients undergoing any procedure, and elderly patients should be managed by a clinical team to determine their best outcome. The high incidence of paravalve leak may have an impact on long-term outcome of TAVI patients, but again, this may change by refinements in the catheter technology. We must remember that every patient is an individual, and everyone should be managed by a team to ensure that every patient gets the best that we can give them. Thank you for your attention.